Okay, well, it's my great pleasure to introduce our friend from Henry Ford Health System, Dr. Tisa Johnson-Hooper, who many of us know very well. She has been with the Henry Ford system for a couple of decades and is the medical director of Henry Ford Health Center for Autism and Developmental Disabilities, abbreviated as CADD. She provides primary care at Henry Ford Health System and participates on the CADD multidisciplinary diagnostic team. Dr. Johnson-Hooper has maintained a long-standing interest in advocating for children with disabilities and has focused her primary care practice on providing high-quality, comprehensive primary care for children and youth with special health care needs. Her research and quality improvement interest includes optimizing developmental screeners for early identification of children who are at risk of developmental disorders, identification of factors which contribute to autism spectrum disorder, and attention deficit hyperactivity disorder, as well as transition of youth from pediatrics to adult approach to health care and integrative mental health initiatives. So I could go on, but let's listen to her talk. The title of her talk is Examining the Social Determinants of Health and Autism Spectrum Disorder. Thank you very much for Dr. Tisa Johnson. Looking forward to your presentation. Please go ahead.
Good morning. Thank you for the introduction. Thank you for having me. It is a beautiful day outside, so I hope you're listening to this talk, experiencing this talk with a little bit of sunshine on your face. So today, we will be talking about examining the social determinants of health and autism spectrum disorder. I have no disclosures. Let's see. By the end of the talk, I hope today that you understand the health disparities that exist in autism screening, diagnosis, and intervention. We'll explore potential factors that contribute to autism health disparities. And lastly, consider what could be done to reduce autism health disparities. I don't want to make any assumptions, so we're going to level set and begin by defining terminology. I'm one of the CAD multidisciplinary diagnostic team members, and so I want to share a story from one of my patients I evaluated in CAD, detailing this particular diagnostic pathway. I anticipate by the end of the talk, you'll be able to identify factors which influenced health outcomes for this patient. We'll briefly review data and spend the bulk of our time reviewing literature, exploring autism disparities. Lastly, we'll consider ways to move towards health equity. So let's begin by defining the term health disparities. According to the Centers for Disease Control and Prevention, health disparities are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. Health disparities are influenced and can surface due to the social determinants of health. According to the World Health Organization, social determinants of health are conditions in which people are born, grow, live, work, and age that impact both their physical and mental health. Examples of the social determinants of health include food insecurity, education, housing, literacy, social economic status, access to health care, and discrimination based on race and ethnicity. The social determinants of health influence the opportunities available to us to practice healthy behaviors, enhancing or limiting our ability to live healthy lives. Now, numerous studies suggest that the social determinants of health account for anywhere between 30 and 55% of health outcomes. making the case that the social determinants of health really should always be considered when providing healthcare to achieve better population health outcomes. So in fact, by identifying and addressing the social determinants of health, health disparities that are rooted in social and economic disadvantages will decrease and health equity can be achieved. So according to the Robert Wood Johnson Foundation, health equity means that everyone has fair and equal opportunity to live the healthiest life possible. So I want to draw your attention to this very familiar image on your screen. The image is a metaphor for health equity. The portion of the image to the left depicts children of different sizes with the same or equal size stool, so they're equal access to resources. So you see the outcome, though, is very different based on the child's size. So in this instance, the child's size is their social determinant of health. The image on the right depicts the outcome when the child's size or their social determinant of health is identified and addressed. Now, each child has equal opportunity to achieve their health outcome. So now let's turn our attention to autism spectrum disorder. Autism is a neurodevelopmental disorder. The symptoms of autism manifest as behavioral changes that present differently based on three things: age, language level, and cognitive ability. So the core symptoms of autism are found in two domains. The first domain is social communication and social interaction. The second domain is restricted, repetitive patterns of behaviors, interests, and activities. A quarter of children with autism will experience a regression in language or social skills, which typically occur between 18 and 24 months. As you may be aware, there are three levels of severity of autism: levels 1 through level 3, with level 3 depicting the highest level of support required. I think autism is like, the popular child in high school. It's never alone. So autism always is hanging around with others. And so autism is very typically co-occurring with developmental, behavioral, or medical conditions. I'm going to now switch and share with you a patient story of mine. I evaluated this little peanut in our Center for Autism and Developmental Disabilities. He presented given long-standing speech, behavior, and learning concerns. His caregiver first noted speech concerns at 2 years during an acute care visit. He received an MCHAT at 24 months at his well child visit, and the MCHAT did not reveal any risk of autism. He did not receive early on at that time. He presented at his 3-year well child visit, again, with a caregiver expressing concerns about his speech. Then the pediatrician referred him for a speech and language evaluation. This was completed approximately 4 months after his 36-month well visit, and he started speech therapy shortly thereafter. Behavioral concerns were raised at his 4-year well child visit. The pediatrician referred the child to behavioral health. So approximately 4 months after that referral, he was seen in child psychiatry and was diagnosed with disruptive behavior disorder, and behavioral management training was recommended. At his 5, 6, and 7-year well visit, the caregiver persisted in her concerns about his communication and his behavior. At 8 years, he was referred back to psychiatry, where psychiatry raised concerns about the possibility of autism. They referred him for an autism evaluation. This was right at the onset of COVID, so I presume it was COVID that led to parents being unable to be compliant with this recommendation. He did, however, receive an educational eligibility of autism when he was 9 years of age. He had a new pediatrician by the time he was 10, seen by that pediatrician at 10, who then referred him for an autism evaluation. 6 months after that evaluation, I saw him in CAD for his multidisciplinary evaluation. At that evaluation, he was diagnosed with autism spectrum disorder, a severity level 2, developmental language disorder, and an intellectual disability. Our recommendations included autism-specific interventions such as ABA, speech therapy and occupational therapy. Multiple medical referrals were made specifically to neurology and genetics. Routine lead surveillance was recommended given his longstanding history of eating non-food items and licking things. His school placement and services were reviewed and endorsed. Autism-specific community resources were provided to the family with particular attention around his safety. He had a significant history of elopement. So after detailing the story, I'd like each of you to just kind of sit with the story for a little bit, sit with his diagnostic pathway, and then ask yourself, is this typical? If you have the ability, I would be really curious and would love for you to put in the chat, what you would consider to have been done differently for this little kiddo that could have changed his health outcome, if anything at all. I want to review the American Academy of Pediatrics autism guidelines with regards to identification, management, and intervention. So first, the American Academy of Pediatrics recommends ongoing developmental surveillance at every well visit. Now, developmental surveillance is the process through which children who may have or who are at risk of developmental delays are recognized. Surveillance consists of many things. It consists of the primary eliciting that parents' concerns. It consists of the provider maintaining a developmental history, observing the child and caregiver interaction, and identifying risk factors like prematurity, prenatal exposures, the social determinants of health, parental health, such as parental depression, anxiety, or substance abuse. It also involves identifying protective factors as well, such as a good supportive family, a lot of peer interaction. Next, the American Academy of Pediatrics recommends routine autism screening using specific autism-specific screening tools at both 18 and 24-month well visits. Now, the use of standardized screening tools may enhance the clinical impression formed through developmental surveillance. The results of autism-specific screening tools are not diagnostic. Rather, the tools are used to identify those children who are at risk for autism. Children who score at the at-risk for autism should then be referred for diagnostic assessment and intervention services. So next is the autism diagnostic evaluation. There's no laboratory tests that are useful to make the diagnosis. Autism is a clinical diagnosis. Comprehensive evaluation consists of a very detailed longitudinal history, formal assessment of language, cognitive, adaptive abilities, and sensory status, along with direct behavioral observation and a physical examination. The final part of the pathway is securing autism services for those children with an autism diagnosis. So children often require early intervention and special education, along with referrals to obtain multiple evals and of systems of care, such as speech, behavioral, occupational therapies, and specialized medical care. The pathway to autism diagnosis and services is not easy. The pathway really should reflect the image at the top of your screen, Plan A. That's really what it should reflect, something that is direct and efficient. Unfortunately, for many, the path of autism diagnosis and services is fraught with misdirection and delays. This is impactful because we know autism can be identified as early as 18 months, and early implementation of evidence-based intervention leads to better outcomes. So the CDC monitors the prevalence of autism through the Autism and Developmental Disabilities Monitoring Network. The CDC estimates 1 in 44 8-year-old children have been identified with autism. Of the children with autism, 3.7% are boys and 0.9% are girls, meaning boys are 4 times as likely to be identified with autism than girls. Historically, the identification of autism was underrepresented in minority families and those with having lower rates of autism among African American and Hispanic families. Since 2018 and 2020, however, the rate of autism diagnosis has equalized among whites, Blacks, and Hispanics. However, we can't get too excited because now, sadly, another type of disparity has emerged. Black children have a much higher burden of intellectual disability than non-Hispanic white children with autism. So among children with autism, 35% have a co-occurring intellectual disability. Of that 35% of children with autism and intellectual disability, 50% are African American, 33% are Hispanic, and 30% are white. So now let's shift. Let's explore the points along the pathway for potential social determinants of health factors that may contribute to autism disparities that we see. So this is not an exhaustive list where factors can impact outcome, but in the interest of time, we'll review some studies exploring health disparities, specifically relating to screening, surveillance, the timing of the diagnostic referral and evaluation, the diagnostic assessment, and the timing and quality of interventions. Okay, so let's start with autism-specific screening. As mentioned previously, the American Academy of Pediatrics recommends universal autism screening, specifically at 18 and 24 months. The modified checklist for autism in toddler, revised with follow-up, or MCHAT-RF, is the most widely used autism screener. The MCHAT-RF is a brief, 2-stage screening tool. The first part is a brief patient questionnaire, followed by an interview for those children who screened at risk for autism. This study, Accuracy of Autism Screening in a Large Pediatric Network by Guthrie et al., was done at CHOP, and it looked at the accuracy of universal screening in the real-world primary care setting and diagnostic outcomes for children, so not just the ones who screened positive on the MCHAT. They included all children with a well visit between 16 and 26 months at CHOP's network of primary care practices who screened for autism using the MCHAT. The cohort included just under 2,600 children. In their institution, universal screening was achieved with a 91% screening rate among their primary care sites. That was awesome. Of the 91% of children who completed the MCHAT, 14% were lost to follow-up. In all, they screened and followed 20,375 children at age 4 to evaluate their outcome. So their major findings. So with regard to the accuracy of the MCHAT, this group found that the MCHAT sensitivity to be 38%. So the ability for this screener to correctly identify patients with autism was 38%. So in other words, the majority of children with autism were not detected by the MCHAT. Additionally, this group found disparities in screening rates and screening accuracy was noted. Even with universal screening practices, children of color, those of lower income households, those who receive public insurance, those with exposed to languages other than English, they were more likely to be missed. The authors of the study were clear and pointed out that providers should continue to screen, as accurate screening positively impacts the age of diagnosis. Providers, though, should be mindful that since the MCHAT does in fact miss some children, they should continue with developmental surveillance and pay particular attention for parents' concerns to inform their clinical impression with regards to making further diagnostic referrals. In the AAP's most recent update to their guidance for identification, evaluation, and management of children with autism, they highlighted the importance of the need for more accurate and culturally sensitive screening practices. I will add, in contrast to CHOP's screening rates, other estimates of compliance rate for autism screening is really only around 43 to 55%. So making the case that we really need to continue to focus on efficiencies in clinical processes and workflows to ensure that developmental screening occurs to identify those children as early as possible who are at risk of autism. I'm just going to keep a running of all of our key points that we derive from our talk. And so for this one, the key point is disparities in screening and MCHAT accuracy based on race, social economic status, and language exist. Okay, as we outlined earlier, developmental surveillance includes providers eliciting parents' concerns about their child's behavior and development. Studies have demonstrated parents' characteristics may influence the extent and or the content of their reported concerns. For example, in one study, parents of lower socioeconomic status reported fewer concerns about their child's development over those families of higher socioeconomic status, and parents of boys reported concerns about their child's development later than parents of girls. In this study, entitled Race Influence Parent Report of Concerns About Symptoms of Autism Spectrum Disorder by Donahue et al., offered insight into the lay diagnosis for Black children by examining whether concerns that parents communicated to health providers about the child's development prior to their diagnosis differed as a function of race. So the study hypotheses were compared to white parents, Black parents would report fewer autism concerns, but there'd be no difference in autism or non-autism concerns. Within each category of autism concerns, Black parents would be less likely than white parents to report a concern, and they would be more likely to report disruptive behavior. So parents were from two sites, one in Atlanta and one in Connecticut. Parents completed the MCHAT during their toddler well visit. The researchers called families of children who screened positive for risk of autism, and they then completed the MCHAT follow-up interview. If the child screened positive on the follow-up interview, the family was offered a diagnostic evaluation. Now, parents were told that their responses on the screener indicated risk for developmental delay in their child, and that evaluation would be beneficial. Autism was explicitly not mentioned. So prior to the evaluation, parents completed a history questionnaire about their child's development. The questionnaire elicited parents' concerns regarding their child. So specifically, they were asked, what was the first thing that made you concerned about your child's development? In all, 174 toddlers participated. Of the 174 toddlers, 72% were male, 28% were female, and 61% were white, and 39% were African American. So table 2 on your right depicts the parental concerns grouped into autism and non-autism concerns for analysis. There were 4 items under the autism concerns and 6 items under the non-autism concern. The study found racial differences in the concerns that parents reported to healthcare providers about their children's behavior before receiving an autism diagnosis. Black parents reported fewer concerns about their child's autism-specific behaviors than white parents. So looking at the image on the right, you'll see highlighted are the differences in the parental autism concerns by race. So 25% and 33% of white parents expressed concerns about their repetitive, restrictive behaviors and social concerns, respectively, compared to 6.9% of Black parents reported concerns about their repetitive, restrictive behaviors, and 17.2% reported concerns about social interaction. So race did not impact the number of non-autism concerns that parents reported, suggesting that the effect was specific to autism symptoms. The image to your left just depicts this difference in graph form. It's easier to look at. And notice that there's no difference in speech concerns by race. So one factor that may explain reports of fewer autism concerns by Black parents of children diagnosed with autism is less knowledge about autism-specific symptoms in the Black population. Cultural norms surrounding the discussion of autism within the Black community may impact a parent's knowledge about the disorder. And additionally, parents of different racial or different cultural backgrounds may also have different expectations and even interpretation of a child's behavior. And so this affects that parent's ability to report a concern. Similar findings have definitely been found in the Hispanic family. Having low awareness of autism has been reported as barriers for Hispanic families accessing care. In one particular study, more than 85% of Hispanics reported 85% of Hispanic caregivers who reported limited English proficiency. They indicated really a lack of knowledge about autism-specific symptoms. Parent underreporting of concerns specific to autism symptoms definitely may contribute to providers missing symptoms of autism and may influence their decision about whether to administer an autism-specific screener or even make a referral to evaluations. Parent concerns is not the sole factor influencing this disparity, as we really do have to consider the role of provider bias, as well as the quality of that provider and caregiver interaction, that communication that influences decisions to make the referral for further evaluation. The key point here is that Black parents report fewer concerns about their child's autism-specific symptoms. Okay. So let's turn our attention to the timing of diagnosis and review this study. The timing of diagnosis of autism in African-American children by Constantino et al. This study looked at 584 African-American children with autism across 4 diverse geographic areas: Emory University in Atlanta, Washington University in St. Louis, Missouri, the University of California in Los Angeles, and Albert Einstein in New York City. There were 2 aims of this study. The first aim was to explore potential drivers of delay of diagnosis, and the second aim was to help clarify the predictor of cognitive variability among African American youth with autism. So parents of children enrolled in the Autism Genetic Resource Exchange across 4 sites completed an event history calendar. This interview detailed their pathway from the earliest point of concern or recognition of their child's development through the timing of their child's diagnosis and efforts to characterize the experience for African American and minority families and characterize obstacles to an autism diagnosis, treatment, and medical care. The mean age was 64.9 months, which came on average a little bit greater than 3 years after the parents reported having initial concerns about their child's language, behavior, or development. What is important to note that in this study, the delay could not be accounted for by financial constraints, as 98.2% of the families reported having some type of insurance at the time of their first concern. The average age of initiation of services was 1 to 3 years earlier than the autism diagnosis, suggesting that services delivered were not likely to be specific to autism spectrum disorder. So among this cohort, factors that contributed to delayed diagnosis included significant wait time to see a professional, lack of professionals, and seeing multiple professionals. Nearly half of the children were evaluated by multiple providers before being diagnosed with autism, with 14% seen by at least 6 professionals before receiving an autism diagnosis. So understanding and mitigating the drivers of diagnostic delays is with great urgency, as delayed diagnosis is thought to contribute greatly to African-American children being disproportionately burdened with co-occurring intellectual disabilities. Delayed diagnosis contributes to those children foregoing the opportunity of autism-specific early intervention. And we know that this early intervention can improve social, adaptive functioning, IQ, and language. In order to gain clarity for the reason for this excess intellectual disability among African-American children, this study then explored the correlates of cognitive impairment within the general population. And so what was striking is that they did not find any association to known correlates. So in other words, intellectual disability outcome was not predicted by factors that we typically know influence intellectual outcome, like prematurity, socioeconomic status, or inherited factors. Our key point here is that parental concerns were noted at least 3 years prior to autism diagnosis among African-American children. Healthcare access is identified as a contributor to delayed diagnosis, and Black children with autism have a higher prevalence of co-occurring intellectual disability than white children. I was particularly interested in the study looking at the Autism Diagnostic Observation Schedule, second edition, or the ADOS. This study looked for bias on this tool based on race and gender. So the autism has widely been used for aiding in clinical diagnosis of autism and is now regarded as the gold standard in autism assessment. The Autism 2 is a standardized, semi-structured observational tool used to evaluate and measure communication, social interaction, play, and repetitive restrictive behaviors. The ADOS is organized into 4 modules based on the individual's chronological age and their expressive language level. So this study examined whether the ADOS systematically underestimates autism severity at the item level based on gender and race. The examined item level bias on 10 items assessing the social affect, and then 4 items assessing repetitive restrictive behaviors across the 3 modules. So the study included just over 6,000 children who were evaluated at autism specialty clinics in the United States. And they found that 11% of the ADOS diagnostic items demonstrated some bias for African Americans versus white children, and for females versus male children. What is significant was the magnitude of the bias was moderate to large in only 2 of the repetitive restrictive behavior items. So the findings from this study suggested that the ADOS-2 generally doesn't have widespread systematic measurement bias across race or sex. However, the findings does raise some concern around the detection, around under-detection, that does warrant further research. Really, overall, there was very little research in this area, and so this study certainly requires some replication. So the key point here is bias based on race and gender was identified in 2 items among the repetitive restricted behaviors, and no systematic bias was found based on race and gender. Okay, so much less is known about disparities in autism services, service access and quality of care as compared to the disparities in screening and timing of autism diagnosis. This paper, Disparities in Service Use Among Children with Autism, a systematic review, it was a literature review of key of studies that address at least one key question. So the questions they identified was one, what are the disparities in service use among children with autism by race, ethnicity, and or social economic status? 2, are there differences in the effectiveness of intervention for children with autism by race, ethnicity, or social economic status? And 3, are there differences in the quality of care provided to children with autism by race, ethnicity, and or socioeconomic status? So based on their literature search, they identified 175 articles. Articles were excluded if they did not address at least one of the 3 key questions that resulted in really them looking at only 11 articles that were reviewed. So the result of that review is that treatment disparities do exist for access to care, referral frequency, number of service hours, the proportion of unmet service needs. The evidence revealed that racial and ethnic minority groups and children from low social economic families have much less access to acute care, specialized services, educational services, and community services compared to those of higher income and white children. The authors did not find any articles which addressed their second question, and as such, they could not really comment on the differences in intervention effectiveness based on race, ethnicity, and social economic status. For the last question, several studies they reviewed revealed disparities such that African American and Hispanic families and those from low-income households reported lower quality of care. The authors called out the limitation of the study being that there was really limited body of literature on this topic specifically. So here are the points for this talk: disparities in access to services, referral frequency, and number of hours based on race and socioeconomic status. Black and Hispanic and low-income families reported lower quality of care. So I want to revisit my patient. I want to assure you that this patient's autism pathway to diagnosis is not an anomaly. This pathway definitely can be described as long and inefficient, and definitely with multiple obstacles. And based on what we've talked about thus far, we can identify some factors that may have influenced these barriers to a timely diagnosis. We definitely see that as caregiver raised concerns really early on. Her concerns were around speech early on and didn't emerge to concerns around behavior until 3 or 4, I believe, till 4 years old. That's right. So based on what we did review, wondering could it be parental or caregiver knowledge about autism specific symptoms that definitely influenced like the content and the extent by which she conveyed her behavioral concerns? We certainly cannot dismiss provider bias and interpretation of behaviors, as we do see that behaviors like repetitive, restricted behaviors, activity, and interest are often interpreted as disruptive among African American children and not assigned to autism-specific behaviors. That can impact that referral most definitely. The child did receive an MCHAT at 24 months, but did not reveal any risk of autism at that time. Unfortunately, this kiddo could not take advantage of early intervention services but consistent with the literature, did receive non-autism services long before the autism diagnosis was given. If we discount the obstacle or the time delay contributed to COVID, this kiddo still had about a 6-year delay from the time concerns were raised until the time he was diagnosed with autism. I love this quote. When one of us is sick, none of us is well. So without belaboring the point, really, I just want to stress it's important to address health disparities to improve health and quality of health for everyone. Um, Definitely the social determinants of health influence one's health outcomes and needs to be addressed at every well visit, every health interaction to improve health outcomes. Let's switch here and consider ways to address to address the autism health disparities that we've identified. I can't underscore enough, research, research, research. Research definitely is needed to focus on the diverse autism population. There really are limited to no studies which are intentional and focus on autism in families from diverse ethno-religious or ethno-racial or regional groups. Nothing on Native Americans, Middle Eastern, Asians, those of Muslim faith. There's just not a lot out there to look at so that we can identify whether or not current processes are effective for all children and can influence their health outcome. We certainly need to improve autism awareness, provider awareness, and awareness at the community level. We need targeted knowledge and information regarding autism in languages that are accessible to community members. I recently evaluated a family from, I think they were from Eastern Africa, and in the evaluation, talking to the father, he really recoiled at the idea of diagnoses being brought up around autism, intellectual disability. He was very clear these diagnoses did not exist in his family, in his community. And it was a real challenge to get to the point for this father to accept this developmental delay. It impacted and impaired their ability to engage, to seek services for their child. And I really struggled to find culturally appropriate information to provide this family. We need to definitely expand on autism specific screening using developmental and use of culturally and linguistically appropriate autism specific screeners. There are those out there that can use screeners by looking at pictures as opposed to written word to really help families identify autism specific concerns at the earliest point possible. One other point that can help mitigate the health disparities is by definitely increasing capacity in the number of providers, specifically in underserved communities, whether it's medical providers, therapists, those providing early intervention, and certainly parent support programs. I can't underscore enough. One ways that we have used to increase capacity in our CAD program is the utilization of telemedicine. Like with all programs at the onset of COVID, everyone went to telemedicine, but we've definitely seen the benefits of telemedicine and are continuing that virtual platform and hopefully expanding upon our virtual platform to increase access and capacity for those in underserved areas. It definitely offers benefit of expanding, access, decreasing cost for families, cost of time, driving, money that people are spending in order to get these diagnostic services when it's not in their area. It's certainly a viable option for families in remote areas and underserved areas. And lastly, the quality of care. One of the studies that we spoke about today was clear that families are identifying low quality of care that they have access to. And quality of care is something that I am particularly interested in. We know that patient satisfaction and engagement surveys are widely used in healthcare. And I conducted a literature search extending back from 2013 to the present, and I discovered that autism specific diagnostic or autism-specific intervention services evaluating quality of care simply don't exist. There were no tools out there that existed. So CAD collaborated with Press Ganey, and we created autism-specific diagnostic patient engagement surveys, one for our feedback for patient engagement, and then one specifically for our ABA program. What we hoped that our patient experience surveys will evaluate the patient's clinical experience with us, including the virtual platform where we're applicable. We want to evaluate how the individual provider communicated with the patient, and then our ability to meet the unique needs of the family based specifically on the child's culture, religious belief, race, ethnicity, gender, nationality, and language. Patient experience surveys at all stages will really be an important way to measure the extent to which our patients are receiving quality care that is respectful and responsive to their individual needs. We hope by being intentional and focusing on quality of care that we will improve health outcomes for the patients that we serve in CAD. I'm cognizant of the time, and I'm sorry I kind of sped up at the end. I think this is my last slide. I want to thank you for your attention, but I wanted to leave a little bit of time if there were any questions that need to be raised.
Well, thank you so much, Dr. Johnson, for your very educational talk. Very interesting. Let's see if we have any questions.
I have a question.
Yeah, go ahead.
Thank you. Hi, Tisa, Herman Gray. Thank you so much for joining us today and for your really outstanding talk this morning. And thanks to you as well for your long-standing efforts in this area of practice. It's a tremendous contribution to our community. I have a question about capacity and availability of services. You touched on that a bit towards the end of your talk. Even though I don't practice any longer as a general pediatrician, even for me, it feels like we're in the midst of this autism epidemic in many ways, and screening consistently, as the A.A.P recommends, is likely to uncover and reveal even more children in need of services. I'm not suggesting at all that we shouldn't screen. I'm curious, is there any element of a maldistribution sort of challenge here with availability? It's my impression, which could, I fully acknowledge, be based on my extraordinary level of paranoia and cynicism, that where the most kids, from a prevalence point of view, are afflicted by autism, there are the least amount of services in those communities. And if that's true, is there any systematic efforts to address it? I get that, one place or another, maybe, increasing their virtual and telemed and all that kind of stuff. But is there anything systematically taking place, in our profession? And if not, what can, a little practice like Wayne Pediatrics do to contribute in a positive way?
Wow, that is a big question. First, it's wonderful to see you. Thank you for the question. It is a huge question. Systematically, I would say I am not aware of anything on a large, grand, systematic way to increase services in those underserved areas. I will say that I know health systems, providers, practices are looking at what can be done locally. I know the University of Michigan they completed a pilot training primary care providers to do a first level diagnostic evaluation with the support of developmental practices, developmental pediatric practices, or autism centers, which definitely has improved their ability to, increase capacity. I know there's a lot of little pilots looking at things like that. It really, quite honestly, I think what I've seen in our diagnostic center is definitely that epidemic that you're describing. But I'll be quite honest, most of the kids we see are the kids that I think a general pediatrician without a standardized tool could, as they walked in, would say, yes, this child has a developmental delay, possibly autism. And I'm saying that to say the acuity, the severity of autism that we're seeing at these younger ages has really increased. And I don't know why, but I can tell you over the 3 years, it has become more of a challenge evaluating these kids because they come with far more complexity. The screeners, I think, are very helpful for those kids that are moderate, that really have subtleties that unless you spend, time with them, really teasing it out, you may miss. I think we need to do a better job of picking up those children with subtlety, because we're definitely seeing more and more kids with complexity.
Thank you.
Thanks.
I have a
question.
I have a question.
Dr. Smith.
Good morning, Dr. Johnson. So good to see you. One question I have is, our challenge isn't necessarily identifying or diagnosing, but it's the treatment side. It's what do we do and where do we steer our families? Because if we have a diagnosis, but it doesn't meet the criteria to access ABA services and some of the systems that will support Medicaid, for example, that's really the challenge.
Not only is that the challenge, I'll go and add an additional challenge. So yes, our Medicaid eligible children, they have to go through the community mental health, county community mental health to access their services. In theory, it is a more efficient way to get services than going through, private insurance. But where I see the challenge, and so I do this every day, and I have kids in my practice that are Medicaid eligible and are tapping into services. It's really the quality of services. I don't think pediatricians are equipped to work with families and evaluate whether the services the child is receiving is appropriate. I had one BCBA tell me that she'd rather a child get no services than bad services. And we went back and forth on this. And, she was sharing with me some of the, quite honestly, horror stories that were occurring with kids that really were not helpful to them. And as a pediatrician, I have not found a general pediatrician that would say, oh yeah, I can evaluate by looking at the plan of care, whether or not the plan of care that is described and the services the child is receiving is appropriate. That's a huge challenge. I know I've worked with my group to try to devise guidelines to provide to families. So when they're going to various ABA programs, it's kind of a checklist of what to look for to help them identify quality services. But to your point, it is a challenge because they're really, you can get the diagnosis. I didn't talk about in my talk. I started to look at what is the time between having the diagnosis and securing services. It is extensive. I know kids will sit for months, many months, without even accessing having access to the services. They have the diagnosis. I wish I had an answer. I just try to learn about all of the ABA programs in my community that my kids are going to, so I can have a contact and to try to be as engaged as possible. But it's a challenge, it's a burden. And so I think more on a larger scale, devising, like I said, some type of checklist for the provider, for the family that can serve in place of having a lot of clinical background and experience, so that the provider knows how to help these families advocate for services. I feel like I don't have answers here. I'm sorry. I'm just empathizing with the problem. I wish I had.
Yes. Thank you.
Yeah, Dr. Ravi has a question.
Hi, that was a very interesting talk. I was quite shocked by the incidence of figures that you mentioned about 1 in 44 children may have autism spectrum disorder, this surge in cases, is there any body of work that's point towards a particular etiologic factor, environmental factor? You did not mention lead at all in your talk, and how much of that is a factor in the ASD disorder diagnosis in African American children?
Yeah, no, you're right. It really is. It's becoming an epidemic. The prevalence increases year over year, it seems, and it certainly has. Not that it seems, it has, and that in part is definitely due to diagnostic shift. The diagnostic criteria has changed notably, and so children that otherwise would have had diagnosis, just like an intellectual disability or like for instance, like Rett syndrome is Asperger syndrome. These diagnoses are no longer used, and so there's that diagnostic shift. The diagnostic criteria has also broadened, so we're capturing a larger population by changing the diagnostic criteria. That is influencing the increased prevalence, but that's not the answer. There's certainly an increased number of children affected with autism. Definitely, it is a genetic underpinning, but there certainly is an environmental factor that we just don't know. There are things, that can raise your risk, but there is no definitive answer as to what is the cause of autism.
So let me follow up on that a little bit. So in some children with increased lead burden seem to have autism spectrum disorder. Now,
so elevated lead levels not causing autism, and it's certainly not helping, right? Because it certainly will influence a child's learning and cognitive abilities, not causing autism. But you see elevated lead quite often co-occurring in children with autism because they oftentimes will have repetitive behaviors of mouthing non-food items, increasing their exposure to environmental lead. So it's not a cause and effect there.
So my question was a little different. I was going to ask you, do you find a significant difference in the spectrum of symptoms or the problems that the autism children with increased lead burden versus those without increased lead burden?
Gosh, that's a big, I don't know. I'm just really thinking, I have quite a few kids with autism and elevated lead, and these are kids who are, again, profoundly impaired, and they're always with, I can't say it's a cause and effect. I certainly do see kids who are more severely affected or more often to have mouthing behaviors or more often to have elevated lead. I don't think it's influencing their autism-specific symptoms, the restricted, social interaction, communication, and behaviors. But I certainly am curious, and we'll see if there's any literature on that. Interesting question.
Well, maybe I could ask the last question. I'm also very surprised, like Ravi, about the incidence. And I just wonder how well are pediatricians trained these days to screen patients for ASD, the newer generation? Are they comfortable making diagnoses like this?
So I don't think they're necessarily comfortable in making the diagnosis because it's a comprehensive diagnosis that you are ruling out other diagnoses that often masquerade as autism or co-occur. So I don't think that is something appropriate in a primary care setting. Pediatricians are not well equipped to do that language assessment, cognitive, adaptive abilities. It's nothing that is done, but certainly there is a role for a pediatrician. You raise the point of increased screening. That is definitely contributing to the increased prevalence. So we need to be aware of that, but there's still ways to go because as we learn, the screening is, in most primary care, can be anywhere from mid-30s to 50%. So we need to screen better and more often. But with respect to training of learners, medical students, residents in primary care, I can say with, definitively, any learner that comes through Henry Ford, we do a lot around educating our learners of the importance of developmental screeners, and not just the MCHAT, but from birth through adolescence, why we screen, what we're looking for, how they're utilized, and knowing that it's just screening for those kids at risk. It is not diagnostic. So it is something that
Thank you very much. We have many comments in the chat box. Most of them thanking you for an amazing talk. But a couple of comments that I would like to share with you.
Please.
One from Dr. Eric Ayers, and he says it's controversial, but it could be due to increased marijuana use and its association to prematurity, going back to the possible underlying etiology for increase in incidence. So that's his comment.
Yeah, prematurity is a risk factor, most definitely.
And then Dr. Cartrini, she says, we hear many parents say that they don't want services and are concerned with labeling, which I'm sure must be happening quite a bit. And any comments on that?
No, that does, the labeling, the concern of stigma is really, historically based. And so that's where it's important to understand the perspective of the parent, that they're not saying that just kind of as a one-off. It really is based on their lived experience. And I think recognizing that and discussing that concern and partnering with a family to develop a mechanism to see services through without that child being, or the family feeling as if that child's going to be marginalized, stigmatized, and forgotten. It really is taking the time to, acknowledge why that family feels stigma. And I can just, in the interest of time, I have a lot of conversations around the various stigmas and different communities that families have, not just around autism, but other diagnoses. I just had a conversation with a Hispanic family around their new diagnosis of Down syndrome from their child and what that would mean to them in their community. But stigma, fear of labeling is significant.
Well, again, thank you so much. And thank you everyone else for joining us this morning, and you all have a great day. Thank you. Bye-bye.
Thank you for your time.
Thank you.